Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Cases from the Community. As today we talk about the management of gastroesophageal and hepatobiliary cancers, and we're trying a format we've never done before in this webinar, so it's kind of like a phase 1 CME experiment. Our faculty today, by video, I met with these two docs. They were both in part of a GI symposium satellite we did in San Francisco this past January. Dr. Lipika Goyal from Stanford University School of Medicine in Palo Alto. She was on the faculty for our program on HCC and biliary tract cancers. And Dr. Zev Weinberg from the UCLA School of Medicine and the Johnson Comprehensive Cancer Center in Los Angeles. Zev was on the faculty of our program on gastroesophageal cancers, and I followed up with them after the GI symposium, and I interviewed each for an hour, no slides, just talking with the whole idea of kind of a program you might listen to. And tonight, actually, we're going to play excerpts of that and have it commented on. This is kind of the reverse of what we've been doing the last 3 years of taking videos from docs in practice and presenting to investigators. Tonight, we're going to do the opposite. So we have three general medical oncologists who are going to be commenting on these very short video sound bites. Dr. Eric Lee from Fountain Valley, California. Dr. Neil Morganstein from the Atlantic Health System in Summit, New Jersey. And Dr. Swati Vishwanathan from the United Hospital Center in Bridgeport, West Virginia. So as always, if you have any questions or cases you'd like to, or comments about what we're talking about today, just type them into the chat room and join the conversation. We put out a very brief 1-minute survey for you to take before this meeting. We get started here, and then we'll give the same thing at the end and see how it changed and learn a little bit about you, and you'll probably get a lot more out of the meeting. We do webinars all the time. We're getting ready to do one on colorectal cancer. We did a satellite in ASCO GI on that one as well. So on the 22nd, we'll hear Dr. Strictly. We'll be presenting cases to him. We're about to head out to the SGO meeting, Society of Gynecologic Oncology. We're doing 2 symposia there that will also be simulcast. One on Sunday, March the 26th, on ovarian cancer, and then the following day on March the 27th, endometrial cancer. 2 super hot phase 3 trials are going to be presented at that meeting. So first-line therapy, chemo plus IO. Have you ever heard that before? Well, maybe it's going to be coming to endometrial cancer. We'll find out when it's presented. We're going to do a program as part of our year in review series on AML and MDS on April 4th. And then we'll finish out our ER-positive triple-negative breast cancer series with Dr. Hurvitz on April 12th. We did this second part of that series last night with Dr. Sarah Tolaney from Dana-Farber. And finally, we'll be doing another year in review program on non-targeted approach. We have to divide lung cancer up nowadays. We can't cover it in an hour. So we're going to do non-targeted and immunotherapy in this program with Dr. Pauzaris and Dr. Wakely. We know a lot of people end up listening to our webinars. If you're into a podcast, check out our Oncology Today series, including a recent program with Dr. Shah on management of gastroesophageal cancers. So here we go. We're about to take a listen to a series of sound bites that average about 90 seconds each. And we'll see what our oncology faculty here thinks about the relevance to their practices, but also how this content fits in. You know, we're used to there are a lot of CME out there where people give lectures. We like to do it a little bit different way. We sort of like to, kind of use a rounds-like approach and really kind of ask people in particular how they take care of patients. And you'll see some examples of this, and we encourage you to watch or listen to the entire 2 programs as well. But let's start out talking about gastroesophageal cancers with Dr. Weinberg. So we like to say short form video is the new slides. No slides tonight other than we're just showing a bunch of video sound bites. So we're going to start out with kind of an overview of the management of localized gastroesophageal cancers. We'll see what our oncologists think about that. Here's Dr. Weinberg.
anything below the G junction, predominantly stomach tumors, I still think the standard of care there is neoadjuvant chemotherapy with FLOT. I usually use that as the dividing line, and patients above it, I generally prefer neoadjuvant chemoradiation with carbotaxol. In cross patients, we have the Checkmate 577 study. We have a clear role for adjuvant nivolumab in patients who have had chemoradiation, surgery, and have some residual disease. Those patients, it's an absolute, in my opinion, unless there's a contraindication, good reason to give them Nivo. And that's independent of squamous or adeno, and that's independent of PD-L1 score, in my opinion. It might work a little better if they have a high TPS score. It might work a little better if they have squamous cell, but it doesn't mean you would withhold it in the context of adenocarcinoma of the esophagus. For patients with stomach cancer who commit to neoadjuvant chemotherapy, and that's times FLOT, the current standard is to continue that FLOT after surgery if they need more FLOT. It's not to change the chemo. It's not to add immunotherapy at this juncture. We're waiting for very, very big studies that may change that paradigm.
So, Neil, I want to start with you. And I should mention, too, that Neil's been in practice for about 18 years, Swati about 3, and Eric about 5. So, one of the things I think a little bit about, Neil, is even though you haven't really been in practice that long, it's a big difference 18 years ago compared to 5 years ago. Before we kind of get into this particular, maybe you can even use this as an example. Any thoughts about what you've seen and how things have changed in general in your practice as a general oncologist, but also specifically related to upper GI cancers and this issue of local therapy?
Yeah, sure. I mean, 18 years, I can't believe I've been doing it for that long. But over the course of time, there were no IOs, there were no targeted therapies. It was honestly a heck of a lot easier. Paradigms are still the same. You try to do neoadjuvant therapy to shrink things and then adjuvant therapy. So in general, that hasn't changed. Our tools have just gotten much, much more complicated in our workups. For gastric cancer, I personally think FLOT in the community setting is not always that easy. FLOT's a tough regimen to give people. And I do struggle with exactly what Dr. Weinberg said. Afterwards, let's say that you've had no great response. Do you give people who had toxicities to FLOT more chemotherapy? And the dangle or the allure of immunotherapy is always out there, and I know the trials aren't there, but I haven't done it, but boy, do I want to sometimes.
And Swati, actually in the program, Dr. Weinberg talks about some of the trials that are looking at FLOT or integrating IOs into the FLOT patients, whether it's FLOT or something else. Again, any thoughts about this kind of scenario in your practice and some of the issues that come up as you try to deal with these patients, Swati?
Absolutely. The first issue when patient presents to us is first making sure we're getting the appropriate staging, EGD, US, PET scan. And sometimes I will say diagnostic laparoscopy also becomes important to rule out peritoneal mets. And sometimes that's a challenge for me to get our surgeon to do the diagnostic lab, because sometimes I've seen patients, we push the FLOT regimen through, and unfortunately during surgery, they're found to have peritoneal mets. So that's one issue. The second issue, in terms of treatment, I rely on my gastroenterologist to tell me if it's predominantly gastric tumor versus a G junction tumor, esophageal tumor, because that kind of changes my approach, right? Because if it's predominantly gastric, I'm going to do FLOT. Whereas if it's like above the gastric level, then I'm thinking more of the cross regimen, chemoradiation, because I would prefer to do chemoradiation because we have the adjuvant Nivo data only after chemoradiation and not after FLOT. So I think talking to your gastroenterologist, making sure you're fully understanding the location, the anatomy, and then choosing the regimen accordingly. That's very important, because I personally right now for gastric, I'm not using immunotherapy. I'm waiting for the data. I would do FLOT, peri-op the 4 cycles, and then take them to surgery and, complete the 4 cycles post FLOT after surgery. And in terms of G junction tumor, I am sticking to the Checkmate 577 regimen, which does not differentiate based on histology or the PD-L1 level. It's strictly if the patient has an R0 resection and has residual disease, I am trying to do the year of nivolumab. But what I have seen, sometimes it is difficult to give that whole 1 year. So I would be curious to know if, say, I do 6 months, or if I don't finish the 1 year, would I still reap the benefits?
So, Eric, I'm going to show you another clip and get your reaction. We're going to start to pick up the pace here a little bit because, one of the things that we've tried to do over the years, is kind of, quote, go beyond the guidelines. A lot of times if you go to guidelines or you go to up to date, you see a whole bunch of options. What we try to get down to is like, what do you actually do in your practice outside a clinical trial? We know it's different for every patient, but like, how do you make an individualized decision? And I think the complexity of that really comes out in this next topic, which is first-line therapy of metastatic disease. So in particular, the one particular issue that we've seen a lot of controversy about is in gastric and gastroesophageal cancer, the use of IO in patients with PD-1 low or absent. So Eric, I'd like you to listen to, we like to ask people what they do, but a lot of times you got to go beyond that and really get into like, how do you discuss it to the patient? Because it's not just A or B. There's a feeling to it. And also, I think we're hearing more and more about bringing the patient into the decision. So I'm going to ask you how you deal with the same situations that Dr. Weinberg's about to talk about in choosing first-line therapy.
Squamous cell of the esophagus, metastatic disease. We have 3 options that I would consider reasonable at this juncture. Number 1, chemotherapy plus immunotherapy, which includes either chemo plus nivo based on Checkmate 648 or based on Keynote 590, FOLFOX or 5FU based chemo with pembrolizumab. Both good options, both clearly benefiting patients in squamous cell of the esophagus, particularly those with PD-L1 high, and particularly those who have high TPS scores as well. Now, you also have a third option, which is Ipi-Nivo. And Ipi-Nivo also is a good option, in my opinion, and based on Checkmate 648, in squamous cell exclusively. Gastric cancer first line and HER2 negative, the dividing line for me is still CPS 5. If you have a CPS greater than 5, in my opinion, the data is strong and the survival and hazard ratios are clearly beneficial for chemo plus nivo. The CPS less than 5, in my opinion, despite having an FDA approval, I just don't use it there. There was a presentation last week on an ESMO virtual of the Keynote 859 study, which by and large, if you just look at the totality of it, more or less mirrored, in my opinion, what we saw in Checkmate 649.
Does it matter to you whether it's 1 to 4 or 0?
Yeah, it's a really good question. Number 1, I have to feel good about the CPS score. So I'll be honest with you, if it's a cruddy CPS report, I feel a little bad withholding an IO in that patient, to be totally honest. So I got to feel good about it. Now, if it's good and I feel good about it and it's under 5, so I am personally not using it in that context. I also practice in the real world. And if a patient comes in having their idea in mind that they need chemoimmunotherapy and they don't leave it up to me, and they're like, doctor, I want immunotherapy, then I do include it, to be candid, because I feel that the patients know a lot of times what they're looking for. And it is FDA approved. And so I don't feel too bad about it, to be honest. And I know that's where the community finds itself in a very difficult circumstance. And so you shouldn't worry about it too much. It's not wrong to use that. I don't withhold it from patients, and I mean that sincerely. I have a patient right now who's saying to me, this is what I want. And I'm like, fine, I got no quarrels with that. I don't want to look at it as, I know all the answers here. That's not the way we should look at it as oncologists.
Do you entertain the possibility of using IO later on in those patients?
Well, I mean, if you're going to do it, I think in a low CPS patient, probably the best time to do it is up front.
So, Eric, we could talk about this all day long, and he was referring to the new Pembro study that was just presented at ESMO, very similar to what we saw with Nivo. There are other investigators, Dr. Janjigian at Memorial, who gives it to people with low PD-L1s. But again, if you really talk to her, she has a lot of shading, very similar to Dr. Weinberg. So, maybe it's sort of somewhere in between. Do you find, Eric, we could talk about the topic a lot, but I'm curious whether you find this kind of content helpful to you in making these difficult decisions.
Actually, the question regarding the the low PDL1, the 1 to 4% is actually a very good topic of discussion, and Dr. Weinberg is correct that what if you get a CPS of 4? how is that really different than a CPS of 6? It's really subjective many ways. One pathologist might read a CPS a certain way, might be reported by a different, pathology group another way. I do present the data to the patients. I do present to them. So let's say we're talking about frontline, metastatic, gastric, and they have a PD-L1, a CPS of obviously greater than 5%. I think it's a no-brainer at that point to discuss with them the benefits of immunotherapy. There's not a lot of benefit if it's 0%. Then in the 1 to 4%, I would actually discuss with the patient. I said that there might be a marginal benefit. It's probably not nothing. And if unless there's a huge contraindication for them not to receive immunotherapy in that situation, we will probably give consideration for giving immunotherapy. It's a very good question because, and also you have to use the correct, PD-L1 assay as well. What if you use the incorrect companion assay, then you might not get the same, a scoring system as you would have, as a clinical trial presented. And so in that regard, in the 1 to 4%, I don't withhold treatment from the patients. I will discuss with them, what the subgroup analysis showed and discuss with them, the pros and cons of adding immunotherapy, systemic therapy.
So again, I'm just kind of doing a little tasting menu here. All these issues we could talk a long time about, but I just want to kind of bring them up and bring in some of your many perspectives, I think, on this topic. Neil, we were talking about how often oncologists are using drugs for the first time. It seems like every day another approval. And here we have now at the GI meeting, zolbetuximab, which has had a big phase 3 trial that was positive, that was presented at the meeting. And could very well be that this is going to be a new agent. It has a different target, Claudin 18.2. I was joking with Dr. Weinberg about whether PD-1 and Claudin 18.2 are going to become the new ER and HER2 of upper GI cancer. But I just want you to listen, Neil, to what he has to say about this. And again, your thoughts about how this might be helpful to you and other kinds of issues that come up when you hear about new trials and new agents. Here's Dr. Weinberg.
It's a first-in-class monoclonal antibody blocking Claudin 18.2, which is a protein that is overexpressed, we use that term in this context, in about 30% of gastric cancer and some other cancers too, by the way, a little bit of pancreas, a little bit of squamous carcinoma of the lung. But what's unique about Claudin 18.2 as an adhesion molecule is that it's present in normal tissue, but only in the stomach mucosa, such that the stomach mucosa by far has the only normal expression of this antigen. 2 randomized phase 3 trials, Spotlight and Glow. Spotlight was just presented now at GI ASCO and reported a 2-month or so improvement in overall survival in the group of patients who got zolbetuximab compared to chemotherapy plus placebo.
But also, in terms of hazard rate, my recollection is for progression-free survival was like about 0.75, but also survival, I think, was about, which was kind of unusual, about 0.75.
There was no increase in response rate in the group of patients who got chemotherapy plus zolbetuximab over chemotherapy plus placebo. I think there's scientific reasons why Claudin 18.2 antibodies don't confer response rate, having to do with perhaps the mechanism of action of the protein. And you're absolutely right, was the secondary endpoint of overall survival, which is a bit unusual that they would both happen at the same time, but I think speaks to the fact that the drug does have significant activity in that select group of patients. It's important for everybody to keep that in mind, that these drugs cause nausea and they cause vomiting. And it's particularly increased on the first time they get the drug. There's an element of tachyphylaxis here, such that on subsequent dosing of the drug, that toxicity is diminished. To be fair, in my experience at least with these drugs, and I've had a few of them, the standard antiemetics aren't as useful. Because you're talking about something that's not a centrally mediated nausea and vomiting problem. It's a GI nausea problem. It's in the GI tract. So there are tricks of the trade to diminish the toxicity, including slowing down the infusion rate, pre-medicating sometimes with steroids and or lorazepam. But, it's not as responsive, let's say, to our classic ondansetron, compazine type of pre-medications, Neil.
So, Neil, any thoughts about this? Of course, the FDA will weigh in on it. A lot of investigators are going to be weighing on it, but also you all have to sit and decide. You know, you have all kinds of different trial results here. You have a lack of response rate increase, but increased PFS, increased survival, even at this first stage. Is this the kind of information that you're looking for when you hear about a new drug, Neil, and any other kind of issues that you like to hear about?
Well, I love hearing about the side effects, but also kind of the workup and how does it compare to our other antibodies and where do we utilize immunotherapies in this? I didn't hear, and to be fair, I'm not sure if you have to check for Claudin 18.2 on immunohistochemistry or NGS. Is this something else we're going to have to train our pathologists to look into? And then it's going to be a lot of nursing education about this nausea issue. The nurses take care of a lot of it. So this may be one of the drugs you kind of wait till it comes out, see if it gets approved, see where it fits in and dabble with it initially. I don't know if this is a home run. I think it doesn't seem like a home run, but it's going to be another tool in our armamentarium.
So another issue that comes up all the time in oncology, and again, I mean, this is not like this 5 years ago, is testing. Not just tissue testing, but now you have the whole arena liquid testing, liquid biopsy, tumor-informed cell-free DNA, and MRD. And let's talk a little bit about HER2 positive upper GI cancer. And of course, one of the issues here is you all already have a lot of experience with HER2 positive disease from breast cancer that the GI people don't. And one of the things that I've been hearing that I thought was really interesting, and Swati, I'm curious what you think about this next comment, is I brought up to him the fact that I see these GI investigators, patients diagnosed with HER2 positive disease. They get first line therapy now with pembro, trastuzumab, chemo. They have progression, and then they repeat the HER2 testing, either tissue, liquid, or both. And if it's negative, they don't use HER2. Where, to me, I think what I'm hearing from the breast people for the last 10 years is once you're HER2 positive, you're HER2 positive. I don't know who's right. And I think, he alludes to some data that supports what they're doing. But anyhow, here's what he had to say.
That's based primarily on a bunch of studies that have shown that for whatever reason, there is a group of patients that, do not retain HER2 beyond progression. And it could be a quarter of them. It could be 30%. Studies have looked at this now in a bunch of smaller studies, but even some randomized phase 2 studies that have shown that's the case. Now, primarily that's been done based on tissue. Those studies are tissue diagnostics. However, because we recognize in the real world the challenges of repeat biopsying everybody, people have gravitated to ctDNA in that context. I agree. My personal preference is still, if they progress on frontline trastuzumab-based therapy, to consider repeat biopsy when making that second-line decision. I try to do it, let's put it that way. And if I can't, I do ctDNA as a surrogate.
Any thoughts, Swati? It's so interesting when you see agents crossing tumor lines. And now, you see the lung people are dealing with HER2, the GI people, not just upper GI, but colorectal. But you all are already coming in with a long history of the anti-HER therapy, using a lot of these agents. Any thoughts about the challenges in these situations, and particularly these issues of repeat biopsies and type of biopsies that really are a part of oncology nowadays?
So I see your point about, us not repeating the biopsy in breast cancer, whereas in GI cancers where we do. And I think this also is important to understand that the way drugs work in different tumor types is probably different, and it's not the same in every cancer type. The classic example with TDM1, we have data, it works in breast cancer, but it doesn't really work in gastric malignancies. So I think we cannot always concur that if something works in one tumor type, it always has to, work in another tumor type. And from what I understand, 20 to 30% patients do lose HER2, on second line. So I think it is important to rebiopsy patients, especially if I'm thinking of a drug like trastuzumab deruxtecan, which has a lot of toxicities, so I don't want to be using it till I'm absolutely sure the patient's going to have benefit. I'm not sure about the data in GI cancers with HER2 low and TDXT, like in breast. So far, I know they have to have the, the conventional 3+ IHC FISH amplification to get it in the second line setting. So I personally would biopsy patients if I can. Otherwise, use liquid biopsy before I talk to them about agents like trastuzumab deruxtecan in the second line setting. That's my personal opinion. I would not continue HER2 treatments without rebiopsy.
So speaking of TDXD, that was the next thing I asked about, which really basically second-line therapy of HER2-positive upper GI cancers. Again, interesting to talk to different investigators about their perception. TDXD, I thought targeted therapy was fairly straightforward until and HER2 low came out. That completely shattered my whole view of what targeted therapy is to start with. Anyhow, here's Dr. Wainberg answering the question of what his approach to second-line therapy is in a patient who retains their HER2 status after chemo, trastuzumab, and pembrolizumab.
If someone's HER2 positive right now and I confirm HER2 positivity, I am using trastuzumab deruxtecan. Based also on the accelerated approval, they have a randomized phase 2 study that showed a benefit of survival in Asia in that context, and we have complementary data in the Western world showing response rate and PFS benefits similar magnitude with trastuzumab deruxtecan.
What about TDXD and CNS disease?
I don't think we have enough data, Neil, to comment on TDXD's role in treating brain metastasis and gastric cancer. It simply is not as common, and it also hasn't been studied in the same manner as in breast cancer. I know that the breast cancer folks have a very potent kinase inhibitor, tucatinib, that crosses the blood-brain barrier and is an effective anti-HER2 therapy for breast cancer. I have a patient right now, gastric cancer, HER2 positive, has a small brain met, 1 to 2 centimeters, not that small. And, I treated it with stereotactic radiosurgery, and she's doing fine. She's progressed through TDXD. I'd love to give her something that can cross the blood-brain barrier. And I've petitioned for tucatinib in her case, by the way, but it's not approved. Yeah.
In breast, they give tucatinib, trastuzumab, and capecitabine. Is that what you would do with her?
That's exactly what I'm trying to do for her.
What about the issue of ILD? For a patient responding to TDXD who develops grade 2, do you re-challenge when they recover?
I look at it as, if I'm fairly convinced that that's symptomatic ILD, even grade 2, I'd be cautious and not use the drug.
So a lot of stuff there in a short period of time. Eric, any thoughts? I found it really fascinating that he was trying to use the HER-Climb regimen in upper GI cancer. Of course, you all know about that and much more experience with TDXD than any of the GI people. Any thoughts about some of the things he was discussing there, Eric?
Yeah, I actually have a patient that I have on TDXD for GE junction cancer right now. Started off with originally had an ERBB2 overexpression on an NGS, and then went back to the original biopsy, was a HER2 FISH positive. So he was originally treated with trastuzumab, 5FU cisplatin, progressed on that. At that time, TDXD was not approved. So I switched the patient over to Nivo. The patient was on Nivo for probably 6 or 7 months, ended up with progression, metastatic adenopathy to the neck. We biopsied that, still HER2 positive. And at that time, TDXD was available. So I put the patient on that. Now, on a whim, I actually restaged a patient, just fully staged, PET scan, MRI brain, because he complained of some blurry vision, and he was found to have multifocal brain metastases. And so I referred him to radiation oncology at the same time already having started the TDXD, and amazing. He ended up having a near complete response to the central nervous system. He never needed any radiation to the brain, and he remains in very good shape right now. So I know for the breast data, they allowed patients with asymptomatic brain mets on the TDXD studies. They did not allow anybody with symptomatic brain mets. There's probably some CNS activity. But I'm a believer. I'm a believer in that TDXD probably has pretty good CNS penetration. And I wouldn't use it per se just for that reason, but I would, if a patient had CNS disease, I would probably reach for something like that rather than going to just a plain trastuzumab based regimen, even if it's off label.
And of course, the issue of CNS mets and HER2-positive breast cancer is something we talk a lot about. There's a huge amount of research. There's a lot of interesting data there. There's actually is data on TDXD in the brain and breast, and the waterfall plot looks kind of like the regular waterfall plot you see there. But then you also have the other option, as he was talking about, tucatinib. Well, we may come back to some of these things. But let's take a little dip into hepatobiliary cancers as well. I'm just sort of listening to wonders. I'm wondering whether this is informative to the audience, whether how they like this kind of approach. So any thoughts in the chat room or letting us know after would be much appreciated. But let's talk about hepatobiliary cancers. I had a great time speaking with Dr. Goyal. So Neil, I'd like your thoughts about this issue, which is a pretty basic question. Actually, one of the docs, when we showed cases at this meeting, brought this up as a question, which is if you have a patient with obvious HCC, do you need to get a biopsy? And in particular, nowadays that we're getting so many NGS, et cetera, do you need to get a biopsy not just for diagnosis, but for tissue? Here are some of Dr. Goyal's thoughts about the issue of biopsy for HCC, Neil.
Luckily, HCC is, I think, one of the only solid tumors that you can diagnose radiographically, and we're glad that that's an option. My own personal practice is in patients with early stage HCC that I'm thinking about transplant in or resection in, and they meet the criteria for radiological diagnosis, including having a background underlying cirrhosis, plus the radiological features of early arterial enhancement and delayed venous washout, and a pseudocapsule, at least two of those three, if they're greater than 2 centimeters. I tend to hold off on biopsy in some of those patients. Any person that I'm putting on systemic therapy, I try to biopsy 100% of those patients, because every once in a while we get surprised and a patient has cholangiocarcinoma, or they have a mixed hepatocellular cholangiocarcinoma, or they have some other diagnosis. So, Neil, any thoughts about that? This is a very practical issue. I found what she had to say really interesting, and also we'll get into the fact that maybe you all are going to start seeing more and more patients going for surgery, because there's a press release out saying there's a positive adjuvant trial. But Neil, any thoughts about what you heard just now?
Yeah, it's very reassuring, and it kind of backs up what I do. We're kind of programmed to get tissue. It's tissue, 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 tissue. And although there are radiographic findings, just in my practice, I tend to see people with more advanced hepatocellular carcinoma, ones who are tending to, if nothing else, contemplate systemic therapy. And I agree with Dr. Goyal. Before I'm going to give somebody some form of IO or targeted therapy, I try to get a biopsy for what that's worth. I know you don't always need to do it. Most of my cases, they've had other malignancies. There's always been an excuse to get it. So I do try for the more advanced cases. In those early stage cases who are going to go to surgery, two things. One, I'm a little bit less involved in them. And second, I'm very comfortable with them going to surgery without a biopsy.
So I appreciate the comments coming into the chat room. Any suggestions for how we might do this better is also appreciated. Actually, I always viewed our work as music rather than education. I like just the feel of it. And to me, like we're just trying a different kind of music, different singers, whatever. So I'm just kind of trying to figure out how the music sounds here tonight. Anyhow, so Swati, here's a pretty interesting question that we see more and more. It was so exciting to finally see something that sort of semi-worked in HCC, atezo-bev. I remember when that first came out, I wasn't even aware if it was presented in an Asian ESMO conference. Next thing I know, everybody was using it. But then last year at the ASCO GI meeting, we had another phase 3 trial using a combination immunotherapy, anti-CTLA-4, anti-PD-1, durvalumab, tremelimumab. Common problem in oncology. You got to compare two trials indirectly. Which one would you use? I was asking Dr. Goyal, of course, everybody's used to atezo-bev. What are some of the situations where now she's thinking about durva-tremi?
Given atezolizumab plus bevacizumab has a VEGF inhibitor as part of the regimen, I always think to myself, do patients have any relative contraindications to getting a VEGF inhibitor? So I find that if people have had recent significant bleeding, if people have at baseline relatively uncontrolled hypertension, despite, for example, 3 antihypertensives, and I worry about them developing further hypertension on the VEGF inhibitor, I think twice about that regimen. If people have significant proteinuria at baseline, that's hard to get on top of, I think about that. Also, of course, in our population, we see people with varices. And so if people have varices that can be treated and, can move forward with atezo-bev, that's my first choice. But if they have, let's say, grade 3 varices and we ban them and they're going to take some more time in order for it to be safe for the patient to be treated, but the patient is having pain, for example, and more urgently needs to start on therapy, that's the kind of patient that I would, treat the varices because I want to be able to give them a VEGF inhibitor in the future. But it might make sense to start with durvalumab and tremelimumab up front. If someone has, advanced heart failure, for example, it might be a patient that I'm less likely to use bev in. But even some people who have coronary artery disease, even if someone has a history of a CABG, I think it's still reasonable to give atezo-bev. It's such an active regimen, and HCC is such a deadly disease that given the cost-benefit analysis, of course, with informed consent with the patient, I think it's still reasonable to proceed.
Any comments on the emerging data of etiology of HCC and IO responsiveness?
We need to be careful about subgroup analyses. There have been some questions around how much patients with NASH respond to immunotherapy, but I would say there are not prospective definitive data showing efficacy of the regimen in one population versus the other. So for now, my personal practice is to treat everybody, regardless of etiology, with an immunotherapy regimen up front, specifically with atezo-bev if they're candidates, otherwise with durva-tremi if they're not candidates. And there are a lot of really smart groups trying to assess the impact of etiology on outcomes now.
So Swati, of course, first kid on the block always gets a lot of attention. People have a lot of feelings about atezo-bev because we really had just sorafenib before. One thing that she mentioned that I thought was relevant, people bring up the issue of toxicity of durva-tremi, and she pointed out that whereas ipi-nivo, let's say in melanoma and other cancers, is maybe a 50% chance you're going to end up giving corticosteroids for autoimmune problems. With this, where you're only given one dose of the anti-CJ4 in the beginning, it's more like 25%. So still, important. Any thoughts about how you're processing this decision? I don't know how often you even see HCC, Swati, and what your thoughts are about this type of content in terms of whether it's helpful to you.
Absolutely. So I don't see a whole lot, but I have seen a few patients with HCC, and I think it's really nice to have two great options. The atezo-bev, of course, transformed our practice overnight with overall survival benefit and a very high response rate of 30%, which we really hadn't seen. And then came the durva-tremi, also with OS benefit and I think a response rate of 20%. So also a very effective combination. And I agree completely with Dr. Goyal. It really comes down to individual patient comorbidities, what their, if they have any autoimmune problems, do they have any bleeding complications? I think it really comes down to managing, looking at their comorbidities and then picking one regimen that is well suited to them. And I think lenvatinib is still also an active player. I have seen patients who have contraindications to immunotherapy where I've had resorted to lenvatinib. When I'm thinking about choosing the first-line regimen, I do get a varicose screen, make sure, I know if they have varices, they're banded. Then I look at, does this patient have contraindications to Avastin? Do they have uncontrolled hypertension? Do they have like a recent stroke? Do they have a thromboembolism, recent clot, which will give me pause to do the atezo-bev? But a patient who does not have any contraindications, I think still atezo-bev will be my first-line go-to. I mean, cross-trial comparisons, I know we shouldn't be doing, but the response rate of 30% is the highest that we've seen when I compare it to other regimens like durva-tremi. But if I am concerned about the bleeding risk, then with bevacizumab, then I think it's very nice to have durva-tremi as an option. And comparing this to Nivo-Ipi, like you said, from what I understand, the rate of steroid use with durva-tremi was still much less compared to the Nivo-Ipi combination. So yes, there is risk of autoimmune side effects, but not as high as as we see with Nivo-Ipi in the melanoma world. So, and as far as the etiology that you brought up, I think it's very interesting. I think there is a signal there that maybe TKIs work better in patients with NASH cirrhosis, but unfortunately, I don't think we have any studies specifically powered to look at this, but I do think we need to do those studies because in the US, the etiology for HCC is mostly in the setting of NASH cirrhosis rather than viral mediated.
So let me just briefly interject. First of all, to thank all of you who've presented so many cases. We presented, I think, more than 3,000 cases from general oncologists since the pandemic began. And just the fact that you're willing to share your practices and your thoughts, in that situation we're so grateful for that. And the other thing is, and I can tell you, all the investigators I talk to admire you all so much for what you're trying to do, keeping up to date. They have enough trouble keeping up with their own stuff. But when we talk about you all, they have nothing but admiration. And I think, what you're saying here tonight is a demonstration of that and what I've been hearing for my entire career. Eric, I want you to react to this next comment from Dr. Goyal. I used to hear a lot of comments before Atezo-Bev came along about by the time they get to the oncologist, the interventional radiologists have destroyed their liver. I think maybe I'm hearing that less now. Anyhow, I asked Dr. Goyal about this issue that we've been asking people about ever since the Atezo-Bev came out, which is how does it affect giving liver-directed therapy? Here's what she had to say.
Now we have so many options, both for localized disease and for systemic disease, that it really makes sense to bring all of these cases to be presented with a team of interventional radiologists, radiation oncologists, transplant surgeons, hepatobiliary surgeons, and medical oncologists. For the first 10 years, when I took care of HCC and we only had sorafenib, I was more likely to push localized therapy for longer because I knew sorafenib was tough. I knew the efficacy was modest. And now that we have Atezo-Bev, I think there is a feeling among multi-clinics that take care of HCC that we don't want to beat up the liver too much because if people develop Child-Pugh B cirrhosis, it becomes harder to deliver systemic therapy. And so that's why having a close relationship with the interventional radiologist and the radiation oncologist, it's a conversation that we all work together to help them.
Any thoughts, Eric? You hear in many different cancer types, people in tertiary centers talking about their interdisciplinary meeting. They have 40 people there, every possible subspecialty. But I'm not sure in community-based practice if you always have that kind of resource available. Any thoughts about some of the points she made? I'm curious what you've seen since the Atezo-Bev came out in terms of the use of liver-directed therapy.
I think that before deciding on any therapy for HCC, a multidisciplinary approach needs to be taken. I don't reflect to systemic therapy for patients right in the beginning. You have to look at the nature of the lesions in the liver. If it, for example, if you have a portal vein thrombosis, that's a relative contraindication for TACE, but perhaps not for Y90. If you have a lesion greater than 2 centimeters, that might be a contraindication for radiofrequency ablation, but maybe not for TACE, maybe not for Y90. It really depends on how much disease they have to begin with. Is the lesion accessible via surgery? Is the lesion accessible via SBRT? All those factor into play before deciding on whether a patient you would jump to systemic therapy. I know that if you give a VEGF inhibitor, it does potentially impair the ability for the interventional radiologist to take an intravascular approach to treat, tumors in the liver. And oftentimes, especially for other GI cancers, let's say for colon cancer, we will actually hold VEGF inhibitors prior to any local directed liver therapy. And so for HCC, it's a similar thing. I mean, I figure if I start someone in Atezo-Bev, it might actually make it more difficult for liver-directed local therapy, such as TACE or Y90. So I think that before making a decision in the beginning, you have to take a multidisciplinary approach. And if I think that there's an option for TACE or Y90, I will actually discuss it with the interventional radiologist before making a decision for systemic therapy.
So, Neil, here's another issue, very practical issue, a first-line treatment of HCC with an IO alone. Here's what Dr. Groley had to say when I asked her if she ever does that. Any situations where you use single-agent IO as first-line therapy?
Yeah, certainly. So if someone has a relative contraindication to bevacizumab, and if I'm worried about the ability of that patient to tolerate immune-related adverse events, the initial 300 milligram dose of tremelimumab, that CTLA-4 antibody can add, a bit more immune-related toxicity compared to, for example, durvalumab alone. So in patients who are a bit older, frailer, and, I actually also look at what kind of social support a patient has, because when patients develop immune-related adverse events, they need help. So how much partnership do I have with the patient's family and friends to be able to manage that patient? To be honest, that goes into my calculus as well for giving them doublet therapy upfront versus singlet immunotherapy. And then for, upfront systemic therapy, we certainly have the data for durvalumab. We have data for, we can consider pembrolizumab, nivolumab. All of these are reasonable options. If you look at the numbers, they look very good for durvalumab. So there's certainly a population for patients who would benefit from durva alone. And it was encouraging that, the efficacy looked similar to durva-tremi in many respects.
Neil, any thoughts about this? And also about the introduction of immunotherapy into oncology practice. There's a short little video of me that's out on YouTube from a meeting in 2015 where I go, there's about to be an approval for an IO in lung cancer. This is 2015. No IOs in lung cancer, right? And I said, your infusion rooms are about to change dramatically. Your life is about to change because immunotherapy was coming in. Any thoughts, again, for people new to oncology about sort of what it's like now compared to before 2015?
Yeah, I mean, and I say this every day in our practice when I teach the residents, the students, the fellows, that it's a game changer. We used to give chemotherapy. I mean, we were talking about using streptozocin or some drugs that didn't work. And now we could say with a straight face that certain, stage 4 cancers, melanoma, renal cell, lung cancer are curable. I mean, it's remarkable. But that came with a cost. I mean, we talk about utilizing steroids in adverse events from immune-mediated drugs. They're no joke. They're hard. They're hard to take care of. And doublet immunotherapies often cause more issues. So I think it has radically changed things, certainly for the better for patients. It's made oncology practice much more complicated.
Not to mention targeted therapy. So, Swati, I'd like you to respond to this other common clinical question that comes up, which is the use of TKIs. Remember those in HCC, both in patients with contraindication. Some of these patients have had liver transplants or, prior history of autoimmune disease. You may not want to even start with immunotherapy. So I asked her about how she approaches those patients. In patients with relative or really absolute contraindications to IOs, how do you sequence the TKIs?
I generally think of lenvatinib and sorafenib. I think they're both good options. Lenvatinib is generally a therapy that I often will go to because of the higher response rate and the encouraging data also that just came out of the frontline study of lenvatinib pembro versus lenvatinib. The overall survival with lenvatinib was impressive.
What's the initial dose that you use of lenvatinib?
I tend to use 12 milligrams in patients who are more than 60 kgs. And I tend to use 8 milligrams in people that are less than 60 kgs. If someone is a little older and frailer, even if they're more than 60 kgs, I might start with 8.
And can you talk a little bit about how you approach second and third line therapy in patients who get either atezo-bev or tremi-durva?
I'll often think about using either lenvatinib or sorafenib. I think it's also very reasonable to consider using cabozantinib or using ipi-nivo in that setting. I think all four of those are reasonable regimens. The jury's not out yet on, which one of these might be the most effective after atezo-bev.
So, Swati, any thoughts about TKIs? Questions you have about that? What do you think about what she said? I was mentioning that we're going to the SGO meetings, and it's interesting. You hear about lenvatinib, pembro there in endometrial cancer and their issues about how they dose, and then you come over here and you hear about it in HCC. Any thoughts about TKIs in general and specifically these scenarios?
So in terms of sequencing, it's still a data-free zone. Most of these agents were studied post-progression on sorafenib. And now that we're using, if you're, using atezo-bev, it's really, if you look at the NCCN, you have everything listed. But I think if I have to think through the options, first line, if the patient is not a candidate for immunotherapy, I would be thinking about lenvatinib based on impressive OS data that came out of the lenva-pembro data that Dr. Goyal was mentioning. I think the OS was 19 months with lenvatinib, which is extremely, amazing, so that would be my first go-to if a patient has contraindications to immunotherapy. And after lenvatinib, I would be thinking about cabozantinib because it has a slightly different mechanism of action. It, hits, I think, c-MET and AXL, which is different from the other TKIs from my review. So I would be thinking of cabozantinib. And then if the AFP is more than 100, you also have ramucirumab as an option. In terms of nivo-ipi, that would be my last option if I've exhausted everything and if the patients have had prior IO, they've progressed and not responding to TKIs, then maybe I would reach to the nivo-ipi regimen based on the melanoma world. We've seen that after single PD-1, we can get responses with PD-1 CTLA-4 combination. So that would be the way I would be thinking through.
So let's chat a little bit about biliary tract cancers. And Eric, I'd like to claim that I made up the saying biliary tract cancers is the new non-small cell lung cancer because of all the targetable mutations they're finding there. It's really amazing what's going on in lung cancer. I don't know if it sounds like it's kind of moving in that direction. But in any event, again, last year at the GI Symposium, we saw another phase 3 study, the TOPAZ study, that people are very excited about. A common strategy, certainly used in lung cancer, many other cancer, adding IO to chemo. In this case, Durva being added to GemCis in the TOPAZ-1 study. Here's what Dr. Goyal had to say about it.
The TOPAZ-1 study was a global phase 3 study of durvalumab plus gemcitabine cisplatin compared to gemcitabine cisplatin in patients with advanced biliary tract cancers. And in that study, the 24-month overall survival was 25% versus 10% in the triplet arm versus the doublet arm. Again, this landmark analysis was helpful for us to think about the benefits of immunotherapy long term. And that was really encouraging. And do I believe that it's a new standard? I do believe that it's a new standard.
So, Eric, any thoughts about that? And also how you process, and almost you contrast what we were talking about before with durva-tremi versus atezo-bev. Now you got to decide between two. Here you're adding on to, some of those already there. A strategy, again, that we've seen that's been positive. What were your thoughts when you first heard about this study, Eric? I don't know if you ever actually used this regimen.
I think when adding PD-L1 treatment as frontline with chemotherapy, my approach, I think of it similar to kind of what I spoke before regarding, let's say, gastric cancer or GE junction cancers when you're adding Nivo to like Fofox, for example. I think it's very important to understand which subgroups benefit from this type of therapy. You're not adding a lot of toxicity, but you're adding a different type of toxicity to the regimen that wouldn't have existed before because you weren't getting immunotherapy. And so again, I would also, so for these patients, it just shows the importance of doing the full workup prior to starting treatment, getting all your markers, getting your FGFRs for cholangio, things like that. to really line up, to figure out what you really want to do from the very beginning. But it's hard to argue if you're talking about a 25% versus 10%. In the Topaz trial, it's very hard to argue against numbers like that. I think that if at all possible, it should be offered to patients.
So let's bring in one more comment again from Dr. Goyle. I was mentioning a whole issue of targeted therapy. You have IDH. I saw there's a new IDH1 inhibitor that was approved in AML, and I don't know anything about that. But we have BRAF, a bunch of targetable mutations. RET, you sometimes see HER2 being looked at in cholangio. So a lot of different, and of course they're very uncommon. But Neil, I'm curious what your thoughts are. We've seen FGFR inhibition now in bladder cancer. We talked about that a couple of weeks ago in the GU symposium. Interesting agents, different toxicity. Again, this issue of having to deal with completely new agents, not like a new chemotherapy, but a new completely different agent. All kinds of side effects we never heard about. I'm curious, Neil, what your thoughts are about this comment from Dr. Goyle in terms of FGFR inhibition.
FGFR2 fusions are seen in about 10 to 15% of intrahepatic cholangiocarcinoma, rarely seen in extrahepatic cholangio, and almost never seen in gallbladder. IDH1 mutations are also seen in about 10 to 15% of intrahepatic cholangiocarcinoma, maybe 1 to 2% of extrahepatic cholangiocarcinoma, and almost never in gallbladder cancer. Then there are BRAF V600E mutations, which are seen in about 3 to 5% of biliary tract cancers. We see HER2 amplification, more common in extrahepatic cholangio and gallbladder cancer, somewhere up to 15% even in gallbladder cancer, and probably closer to 3 to 5% in intrahepatic cholangiocarcinoma, with ECC being in between. FGFR2 fusions are unique in that you do see responses to the FGFR inhibitors. So, for example, with pemigatinib, the first drug to ever be approved in cholangiocarcinoma, it's a reversible ATP competitive inhibitor. The response rate was 36% in patients with FGFR2 fusion or rearrangement positive cholangiocarcinoma. Having a response rate of 36 to 42% in a fusion positive population, that's good, not great. Like what we see with ALK inhibitors, ROS1 inhibitors. So we can see response rates of 70 to 80%. So there's a lot of research going on right now about primary resistance.
What about toxicity?
The 5 or 6 most common things we see are the hyperphosphatemia, certainly across drugs, and the stomatitis or mouth sores, the hand-foot syndrome or palmar-plantar erythrodysesthesia, diarrhea, and the nail toxicity that we see where the nails become brittle, sometimes lift off, sometimes their nails actually fall off, unfortunately. And then we rarely, luckily, see some of these ophthalmic toxicities, central serous retinopathy that we see. In all cases that I've seen, the CSR has been reversible. We stop the drug, the floaters go away, and we follow them closely with ophthalmology, but certainly a concern that we need to take seriously and follow closely for our patients.
So I love the 5 or 6 most common issues are. Again, being an oncologist is amazing. Any thoughts about that, Eric? Also, the trend in oncology in general to look for things that are very uncommon, targetable lesions, so many situations, MSI, for example, lung cancer, where we're looking for mutations that occur in, less than 1% of patients. Well, of course, most of these patients don't have any of these things. Any thoughts about what Dr. Goyle had to say, and also in general, what it's like kind of looking for these very rare syndromes and having to be ready to know what to do with it?
Mm-hmm. So I won't lie, I have checked for FGFR for all of my cholangiocarcinoma patients. I have never had one. I think it's very important to run the appropriate assay as well, because we're looking for an FGFR rearrangement. Usually you need an RNA-based assay to detect it. So if you do a regular NGS, you might not find it. So you have to understand how your NGS works and whether they reflex it to an RNA expression whole exome sequencing assay. I agree. Oftentimes we do search for very rare mutations. For lung, we're kind of lucky because we just run the whole lung panel, right? So it almost becomes kind of a moot point because we're looking for the common mutations. But, if we happen to find an uncommon mutation, we go, okay, we'll pivot to that. For cholangiocarcinoma, you're basically looking for FGFR, and it's very rare. I mean, I've never found it. For MSI high, it gets more rare the later stage for colon cancer. So, I think that for stage 4 colon cancer, MSI high is very rare. It's like 2 or 3%. But it is fairly common in like stage 1 colon cancer. It might be up to like 30, 40%. So, the more advanced these cancers tend to be, I think that sometimes you find that the mutations are also more rare. But I agree. We often look for needle in a haystack because, that's how aggressive these cancers are. And we want to find our patients an option.
So, Eric, Swati, and Neil, thank you so much for joining us tonight.
Thank you.
Thanks to Dr. Goyle and Dr. Wainberg for working with us on this program. I feel good about it. I don't know. I'm curious to see, particularly if anybody didn't like it, let us know. Coming back, we're going to talk about colon cancer, HER2-positive colon cancer, cell-free DNA in colon cancer, neoadjuvant IO. You didn't hear about that 5 years ago, right, Neil? Anyhow, that's the new colon cancer. That's the new oncology. It's a lot of fun, exciting, but also tremendously challenging. Be safe, stay well, and have a great night. Thanks, Eric.
Thank you.
Thanks, Swati.
Thank you.
Thanks, Neil.
Thank you. See you.